Yeah, but I still don't have the control to share my slides.
Yeah, I promoted you to panelist. Okay, let me introduce you. So it gives me a great pleasure to introduce Dr. Al Hussaini. Dr. Al Hussaini is the acting chair of the Department of Cell Therapy and Applied Genomics. She is also a consultant histopathologist at the Department of Pathology and Laboratory Medicine and a full member at King Hussein Cancer Center in Amman, Jordan. She has a significant interest in CNS and in particular in pediatric brain tumors. She is an active researcher with more than 150 publications in the peer-reviewed journals and 9 book chapters. She has been invited to speak at local, regional, and international meetings to cover topics in pathology and bioethics. Now she will be discussing laryngeal epidemiology and pathology. Welcome, dear Dr. Al Hussaini. The mic is yours, and go ahead and share your slides.
Thank you very much for the kind introduction. Okay, you have to stop sharing your screen so that I can. Okay. Can you see my screen well?
Yes, we do.
Brilliant. Thank you very much for the kind introduction. It gives me great pleasure to be among the great team that was assembled to introduce, perhaps this is an initiative, as I understood initially, to try to spread the knowledge and education about laryngeal carcinoma. So well done. This is the outline of my lecture. I'll be talking a little bit about epidemiology and risk factors and pathogenesis of laryngeal carcinoma, but I'll be spending most of my time talking about the pathology, and I alluded to divide the lecture into pre-analytical phase and analytical phases, as we do actually when we encounter cases in general in the pathology, in pathology reporting. So to start up with epidemiology, this is from the most recent GloboCan 2020, actually ranking incidence and mortality for cancers in general. Now, laryngeal carcinoma ranks as the 20th most common type of malignancies worldwide, and unfortunately, it is still ranking as the 18th most common cause for mortality in relation to cancer. Now, all in all, it accounts for around 0.6% of all cancers, but if we collect all the cases of laryngeal carcinomas, the prevalence of the tumor over a given period of time, an excess of 1 million individuals worldwide are affected with laryngeal carcinoma. Remember that this is the second most common respiratory tract malignancy following lung carcinoma. Now, it's important to remember that there is a difference in the incidence and the mortality between males and males. It's much more common in males in comparison to females, and the peak age is usually around 65 years of age. Now, this is actually the heat map for the incidence of laryngeal carcinoma, and the darker the blue color is, the higher the incidence is. And if we focus or zoom in here into our region, unfortunately, we are among the more common areas with the higher incidence of laryngeal carcinoma, and this is actually as well parallel to mortality. Of course, this comes at no surprise because of the association with risk factors, which is in a way related to the pathogenesis. And the most important risk factor, which is so prevalent in our area in the world, is smoking. So there is a strong correlation or association with cigarette smoking in relation to the frequency, to the duration, and to the number of packs per year. And surprisingly, it takes almost 10 years to achieve a reduction of 2/3 in the incidence once a patient decides to quit. So, on the other hand, around 1/3 of individuals who decide to quit smoking after 10 years will still harbor the same risk for the development of laryngeal carcinoma. This is also associated with a high volume of alcohol intake, and both cigarette smoking and alcohol intake, if taken together, they have a strong synergistic effect. Gastroesophageal reflux disease appears to be also associated with an increased risk for the development of laryngeal carcinoma. Now, high-risk HPV does not play a major role as opposed to other types of cancer in the head and neck, in particular in the oral cavity. Now, in the pathogenesis, we know that the tumor in around 50% of the cases is associated with P53 mutation. CDKN2A is frequently inactivated in laryngeal squamous cell carcinoma, and whenever we see CDKN2A in any type of cancer, almost this imparts poor prognosis. EGFR or HER1 appears to be expressed in head and neck squamous cell carcinoma, including laryngeal carcinoma, but unfortunately, this does not translate into response to targeted treatment. In occasional cases, really, this is a rare occurrence. The PIK3CA mutation rarely occurs in laryngeal carcinoma, but when it does, this is associated with potential for response for targeted therapy. Now, moving into the main bulk of the lecture, talking about pathology, and as I explained before, I alluded to divide it for better comprehension of how we pathologists really work and report on our cases into pre-analytical phase and the analytical phase. And in the pre-analytical phase, this is where really we don't, as pathologists, have much to say. We don't have much power. What we really need is collaboration and feeding of information and data about the patient from the rest of the team, the multidisciplinary team managing patients with laryngeal carcinoma. So, for example, we need to know whether there was a previous history of biopsy or any previous history of resection. Importantly, whether the patient received any form of a treatment, whether this is neoadjuvant or adjuvant radiotherapy or chemotherapy, because you will be expecting us pathologists to comment on the response to treatment. And if we don't have this information, the pathology report will appear to be lacking. Details of surgery are also very important, and whether this was in the intent to be curative or palliative. And importantly, as well, we have to correlate with preoperative radiology in order also to be able to understand the extent of the disease, the invasion, the extent of the resection, the extent of the disease. And this is usually best provided through the presence of multidisciplinary teams or clinics where most of these issues will be addressed. Now, the analytical phase in pathology starts when we receive the specimen, whether this is a small specimen, a biopsy specimen, or a laryngectomy specimen. This is where the analysis and the interpretation as pathologists start. Now, the analytical phase for pathology is divided into macroscopic, where we have the specimen intact, and then we have the microscopic, where we sit behind the microscope in order to render the diagnosis and the associated risk factors that we as pathologists should report. Now, for the macroscopic phase, it's extremely important to have a proper orientation for the specimen, and we usually depend on certain landmarks that would help us to orient the specimen properly. And what we also utilize is a coloring the margins. We have special colors that can withstand the harsh environment of the processing and the formalin fixation that occurs while we are processing our specimens. And this helps us a lot during microscopic interpretation of the specimen. Then once we have the orientation and the inking completed, we have to start slicing the specimen, bread loafing the specimen into intervals of around 3 to 5 millimeters. And then we have all our fragments or pieces or discs oriented in order And this is when we start to locate exactly the tumor, the relation to the inked margins, to the major structures. And this is how we submit our slides or blocks for microscopic examination. So it's extremely, the macroscopic part is extremely important, because if you don't really gross or examine macroscopically the specimen correctly, there is a potential for loss of important landmarks associated with important for the microscopic reporting. Now, the microscopic part, this is the part where we sit behind the microscope and try to come up with a diagnosis and differential diagnosis and sort out the major risk factors pathologically that are associated with the tumor. Now, remember that under the microscope, most of laryngeal tumors are actually, they originate from the mucosa, so they are carcinomas. And most frequently, these are squamous cell carcinomas. And we have a range of lesions. We have a precursor lesions. We refer to these as dysplasias or squamous cell squamous intraepithelial lesions. And then we have the invasive tumors, which are broadly divided into conventional squamous cell carcinoma and the special types. And I'm going actually to spend some time talking about the special types because of the importance of association with the prognosis and the importance of with the, sorting out or differentiating them from some differential diagnosis elements. So always, whenever we have a case, we have to see whether this is, we have really to be clear whether this is a precursor lesion or invasive tumor, and then whether this is conventional squamous cell carcinoma or a variant. And always at the back of our mind, we have to make sure that we are excluding other important differential diagnoses. Now, into the first and most important, one of the most important features that we look for while reporting tumors is the epithelial dysplasias. There are three components to the definition. We have a spectrum of architectural and cytological changes in the squamous epithelium as a result of accumulation in the genetic material, with the associated increased risk for progression. If left untreated, there is an increased risk for progression to invasive squamous cell carcinoma. It follows in general the epidemiology, the anatomic location, the distribution follows in general invasive squamous cell carcinoma or laryngeal carcinoma, because it is a risk factor for laryngeal carcinoma. One important note is usually laryngeal epithelial dysplasias are asymptomatic. What usually the patient might notice or the physician sometimes is just change in color, leukoplakia or erythroplakia. The dysplasias in general are not associated with mass forming lesions. Because of that, this is very tricky and can be easily missed sometimes by, if not, this is really kept at the back of the mind of the physician. Now, under the microscope, pathologically, we classify the laryngeal dysplasia into low grade, high grade, and carcinoma in situ. And again, remember, for us pathologists, when we see a specimen, for example, a laryngectomy specimen that does not have mass, it doesn't mean that it does not have carcinoma, it does not have dysplasia, because dysplasia is not associated with any changes in the macroscopic appearance. How do we differentiate the low from the high grade and carcinoma in situ? It depends on the presence of atypical cells in the low grade occupying the lower third, sometimes the lower half of the epithelium, but then the rest of the mucosa matures as usual. When it becomes high grade, is usually full thickness apart from the very upper layers of the epithelium where it starts to mature. In carcinoma in situ, there is full thickness dysplasia involving the highest levels of the epithelium. But remember, in order to differentiate it differentiate carcinoma in situ from invasive carcinoma, the basement membrane here at the very end of the lower part of the epithelium should be intact. It's an important way to differentiate carcinoma in situ from most types of invasive carcinomas. Now, moving into invasive carcinoma, the most common type, the one that we mostly encounter, is the conventional squamous cell carcinoma. And what we see, this is the surface epithelium with dysplasia, and then there are tongues of epithelium, dysplastic epithelium, invading into the underlying subepithelial connective tissue, sometimes in the form of irregular islands, sometimes in the form of cords associated with dysplasia. Now, one thing that a pathologist, reporting pathologist, should address whenever we talk about conventional squamous cell carcinoma is a grade. It is acknowledged that there is inter-observer variation between different pathologists when assigning a grade. However, it remains an important prognostic feature that should be mentioned in pathology report, and we really assign the grade according to the worst area that we have within the tumor. The well-differentiated squamous cell carcinoma simply looks like the usual squamous epithelium, easily diagnosed once we have the protruding tongues into the subepithelial connective tissue. The moderately differentiated squamous cell carcinoma, we still have some keratin whorls present that would suggest that this is, or support that this is a squamous cell carcinoma. The issue is here really with the poorly differentiated squamous cell carcinomas, where even in a small biopsy, pathologists might get confused or not sure whether this is a squamous cell carcinoma or not. Of course, with laryngeal resections, things become much easier, but on biopsies in particular, it might be difficult or challenging, and we have to use some special stains like immunohistochemistry in order to render the diagnosis. Importantly, at the back of our minds, we have, especially on biopsies, to make sure that we are not over-calling a benign lesion into conventional squamous cell carcinoma. And here comes two important differential diagnoses. Pseudoepitheliomatous hyperplasia, this is a granular cell tumor, and then we have a proliferation, hyperplastic proliferation of the squamous epithelium with irregular tongues, really mimicking a squamous cell carcinoma. So in a superficial biopsy, a pathologist might easily miss this as a squamous cell carcinoma. It's usually when we have generous biopsy or resection specimens when we see the granular cell tumor, and we can confidently establish the diagnosis of hyperplasia. The other less common but important differential diagnosis is necrotizing cyalometaplasia, where we have glands undergoing squamous metaplasia and necrosis. And again, a small biopsy, this might sway away the pathologist from making the right diagnosis. Now into the subtypes. I will start with two subtypes that are associated with good prognosis, the first of which is verrucous carcinoma. Again, this is a nightmare for any reporting pathologist because of the differential diagnosis with papilloma. Papilloma really, especially with biopsies, papillomas are very difficult to differentiate from verrucous carcinomas because superficially they look alike exactly. How do we differentiate them? It's by looking at the lower or deep part of the tumor, where we see the tongues of the tumor extending beneath the epithelium, the surface epithelium. This is the only way to make a confident diagnosis of verrucous carcinoma. Now remember, although this is called verrucous carcinoma, this is not associated with HPV infection. It is associated with good prognosis because this is non-metastasizing. And remember that we need a generous biopsy in order to render the diagnosis. The other important differential diagnosis for or special type of carcinoma associated with good prognosis is the papillary squamous cell carcinoma, where we have many fronds, exuberant papillary proliferation, but this time the papillae are lined by highly atypical cells. This is associated still with good prognosis because most of the tumor actually grows in an exophytic rather than endophytic into the subepithelial connective tissue. This is where really the trick for the good prognosis associated whether with verrucous carcinoma or with papillary squamous cell carcinoma. Now remember that in order, this is squamous papilloma and papillomatosis, important differential diagnosis that we should always have at the back of our minds whenever we encounter verrucous carcinoma or papillary squamous cell carcinoma. Remember that squamous papilloma and papillomatosis are actually associated with low risk HPV infection, HPV 6 and 11, and mostly these affect the vocal cords and the ventricles, and they are associated with symptoms. In order, again, to render a confident diagnosis, we have to have generous biopsy and, of course, correlation with other ancillary studies, including the radiology. Now, moving into the subtypes of carcinoma or the variants of squamous cell carcinoma that are associated with poor prognosis. And the first of these is the basaloid squamous cell carcinoma. It is rare, but it is aggressive. It usually occurs in the supraglottic part of the larynx, tend to occur in older white patients. This is among the rare subtypes that is associated with HPV infection, and we have always to rule out other types of carcinomas, in particular in neuroendocrine carcinoma. So we have to apply immunohistochemistry, adenoid cystic carcinoma, and nut carcinoma. Now, typically, this type of cancer shows what we call it the jigsaw pattern of a growth. So we have glands that just align with each other, similar to puzzle. Under high power magnification, these are basaloid, showing central necrosis, and we usually do P40 immunohistochemistry to confirm that these tumors are actually squamous in order to rule out the issue with the differential diagnosis. Another tricky type of cancer, again, aggressive type of cancer, rare type of cancer, but unfortunately, frequently misinterpreted as sarcoma, is the spindle cell squamous cell carcinoma, or the metaplastic carcinoma, or formerly used to be known as carcinosarcoma. What does this imply? We have a carcinoma that differentiates along sarcoma lines, but the origin of the tumor is carcinoma. It usually occurs in middle-aged to elderly individuals. This type of carcinoma is associated with radiation history, and unfortunately, this is associated with poor prognosis. For us pathologists, we see spindle cell proliferation. We have to do immunohistochemistry, in particular cytokeratin and P63, in order to confirm that this tumor is carcinoma and not sarcoma. One important clue is actually the overlying dysplasia. If we have an overlying dysplasia in the surface epithelium, this is the best clue that we're dealing with the spindle cell squamous cell carcinoma rather than laryngeal sarcomas, which are associated with a poor prognosis. Adenosquamous carcinoma, this is a rare biphasic carcinoma showing squamous, as in here, and adenocomponent, as in here. It's usually, again, much more common in males, usually in elderly, and is associated with poor prognosis. Now, this is important to identify and separate from the important differential diagnosis, which is a mucoepidermoid carcinoma associated with mammal 2 translocation, because of the difference in the prognosis. Usually, mucoepidermal carcinomas are associated with better prognosis in comparison resistant to adenosquamous carcinoma. And remember the important benign differential diagnosis, necrotizing myelometaplasia, that should be always kept at the back of our minds whenever we encounter a case of adenosquamous carcinoma. Now, lymphoepithelial carcinoma is an exact mimicry to the lymphoepithelial carcinoma that we see in the nasopharynx. It's usually supraglottic. It's very rare tumor, mostly seen in elderly males, and it might be associated with EBV infection. Remember that the differential diagnosis for us as pathologists is large cell lymphoma and melanoma, but simple immunohistochemistry, which is cytokeratin, pancytokeratin, would help to show the tumor cells and to sort out the differential diagnosis. So once we have in the analytical microscopic phase the tumor and we start working out on the differential diagnosis, sometimes the cases are straightforward, but sometimes we need the help of some ancillary studies. These mostly are in the form of immunohistochemistry, where we have positivity with cytokeratins, and we have a nuclear positivity for P63 and P40, or in particular, these two last markers would support that this is a squamous cell carcinoma. And then we have a large number of immunohistochemical stains that help us to rule out the differential diagnosis of other entities. Now, more recently, we started to see more and more orders for PDL1 immunohistochemical staining in order to see if the patient will be candidate to receive immunotherapy. And what we usually do is what we call the combined positive scoring, where we look at the tumor cells as well as the background intimately associated inflammatory cells, in particular lymphocytes, and we score them. And if the score is equal or more than 1, the patient is candidate to receive immunotherapy. Not much in the way of molecular testing to help better resolution of cases of laryngeal carcinoma. Now, once a pathologist establishes the diagnosis, whether with or without immunohistochemistry, there should come the second role of pathologists in the microscopic analytical phase, which is to specifically mention whether the prognostic factors such as the depth of invasion, the perineural invasion, the lymphovascular invasion, the pattern of invasion, extremely important, because we have cohesive versus non-cohesive tumor budding, a tumor infiltrating lymphocytes, and then the status of the invasive carcinoma. Also importantly, prognostic factor is the status of lymph nodes, which are frequently submitted with the laryngectomy specimens. We have to macroscopically mention whether these lymph nodes are positive or negative, and then we have to submit the lymph nodes in total, because some of what looks like negative lymph node macroscopically will turn out to harbor occult metastasis microscopically. Because of that, we have to submit the lymph nodes in total. We have to look and mention explicitly the cross-sectional diameter of the largest lymph node metastasis, and whether there is extranodal extension outside the rim of the capsule. And this is again further divided into more than 2 millimeter or less than 2 millimeter extranodal extension, because it appears to be associated with the outcome. So in conclusion, laryngeal carcinoma is among the most common head and neck malignancies. There is definitely a global variation in incidence and mortality, parallel to the risk factors, in particular smoking and alcohol consumption. And pathology shows a range of subtypes, whether the pre-invasive or the invasive. And then in the invasive, we have the conventional type and the other variants or the patterns that would really initiate lots of differential diagnoses. Sometimes we have to depend on ancillary studies, in particular immunohistochemistry, in order to render the appropriate diagnosis. Reporting pathologists should always be aware of the various prognostic factors that I've mentioned that should be explicitly commented on in the pathology report. And pathologists are important part of the multidisciplinary team because the management of patients nowadays depends on the collaboration and the coordination between the different members among the same team. Thank you very much.